Welcome to my dear friend, Professor Antonio Lacy. Professor Lacy is the chair of digestive disease surgery at Hospital Clinic in Barcelona, recently ranked as one of the leading hospitals in the world. He's at the University of Barcelona as a professor, and in addition, he's the founder of the globally renowned Advances in Surgery channel. Of course, Antonio is an honorary fellow of the American College of Surgeons. Welcome, Antonio.
Thank you very much, Steve.
I'd like to talk to you about the AAS channel and video-based education because you clearly were ahead of the curve in offering free video-based education long before COVID-19 and the necessity of utilizing video-based education and communication for surgery and for medicine, and in fact, for the public at large. So perhaps you could walk us through a little bit about how AAS channel came to be and the mission of the AAS channel.
Yeah, at the beginning, thank you for the question, because at the beginning of the AAS channel the mission was try, to incorporate it for the majority of surgeons around the world, the same opportunities. Because probably only between 3 and 5% of the surgeons can travel in a different meetings, to teach, to learn different, what is the new things is going on in general surgery. And that is the reason because we created this and we send to everyone absolutely free. It's one of my, my pillars is free, has to be free, because during this time, the different CEOs decided, okay, we need to pay a little bit, 10 euros for this, $10, etc. But we decided, no, that has to be absolutely free. And after that, we created, an organization, and now the organization seems not too many years, because the idea started, 10 years ago, and we discussed with and you remember with Professor Wagner and Professor Radner in a hotel here in Barcelona. It was probably around 8 or 10 years, but probably AAS started 7 years ago with only videos. And now we have videos, we have open classroom, we have courses, we have education and technology and many things. And of course, it's important because I can speak a little bit about what's the influence of the COVID-19, even in AAS.
Well, the first thing I'd like to touch on is the free education, which obviously helps differentiate, because traditionally one would have to pay to travel, pay to stay and eat at whatever location the meeting's being held, pay the registration fee, and learn, plus lose, in addition to the time away from work, during the meeting, the time away from work, traveling to and from the meeting. Now the paradigm is you can lose less time, only the time necessary essentially for the educational component, not the travel component. So you're not losing as much revenue at work and you're not traveling. And there's no registration. So how is the education funded if the participants are not paying for it?
That could be, the answer is, I will answer, of course, the truth. But the truth, I think we need to change. And that is, we are now trying to move forward to change the way. Because at the beginning, it's everything based and founded with the industry. So, the most important industries related with the surgery pay a certain amount of money, sometimes per event, sometimes per month, sometimes per year, like a course. But that is, I think, was good because it was at the beginning, but that is not the ideal thing. Because always you have to, it's like you make a congress and you need to have sponsors, and that is not the ideal one, because the most important thing is that to create the best, contents in the platform, not because we are losing 70% of our energy and time trying to find a fund.
You alluded earlier to the impact of COVID-19. So we're percolating along at a steady state for let's say 6 years or 7 years before COVID-19. Just to put it in context, How often were you having broadcasts before COVID-19, and what was your typical viewership for the free online education?
Before COVID, we have a minimum twice. The surgical open classroom is 3 times per week. We try to demonstrate, how to put a central line or how is classification of hernias, etc. But minimum, to make like congresses, like life surgeries, etc., is minimum 2 eyes per month. And that's because we have some experience on this, and we created, I don't know, we created with you, with other good friends, let me say, congresses. At the beginning was hybrid congresses. Another time was a congress without, you can be in your hospital, you can record, or even in live, you can be in the as you mate, in the different events in AIS. And that was very good because our experience was very good. When we decided, and I think you, Cleveland Clinic, I think, and Mayo Clinic was the first one to say, okay, life surgery is probably not the ideal one because some surgeons can have some stress on extra stress and influence and can be negative for the patient. And we decided to do something like live, but was recorded, non-edited, 24 or 3 days before. And the surgeon comment the operation and can be better. Because for people like me, for me, it doesn't matter, to talk at the same time. But I think it's not ideal because the ideal is you have to be focused in the patient, in the disease, and to try to make the best surgical technique for our patients.
Although there is a lot to be said for watching somebody operate in an unedited version, whether that is live or delayed live, deferred live, being able to see the decision making in an unedited format. And certainly you and I both have experiences where the decision making during surgery changes because the situation in the surgery changes, and that's exactly what people want to see, not necessarily the simple straightforward where everything goes as planned, because those quick changes, thinking on your feet, how does the algorithm work, how do you troubleshoot, is what people find valuable. The other thing you mentioned was COVID-19. So how did the frequency and content offerings of the free education from AS Channel change with COVID-19?
Yeah, COVID-19 was an explosion for us. And I don't know exactly how many, meetings we created. But our record in viewers means IPs. We don't know is a one IP is watched by 3 people or only for one person. But our record event was last meeting in London with, I think, 30 something, I don't remember exactly, 30,000 people IP connected. However, the record was during the COVID-19 now, because the event was almost 40,000 people connected. And that is crazy, because probably it's more general. Another good metrics is in 11 weeks, we have 2.7 million visitors in the AIS COVID-19. And people, surgeons or non-surgeons, made online courses finished by users in more, that is crazy, in more than 225,000 courses. Could you imagine? When the people, gave me these numbers, and I say, oh, you commit a mistake. I thought was, I don't know, 200 or 2,000, but 200,000 is crazy. And that's created an incredible thing. And I think is even now is a very good, because we have experience, from around the world. from the, where is the COVID origin in China. We have the people decided to do the lockup in Wuhan. We have people from your hospitals, yourself, many administrators. And I think, probably at the end of this, I hope the end will be as soon as possible. We can create something together with all the material, because you cannot imagine. We have incredible numbers and metrics in material related with the COVID-19.
You mentioned that it could be surgeons watching or healthcare professionals or others. Is there content that's geared at patients?
Yeah, in our platform, is not restriction at all. Even patients, you just put you are a patient, you are a surgeon, you are something. But they can be, and many people I know, at least in my city in Barcelona, their hospital administrators decided, okay, that's it is an excellent when they, some of them come back, even not in their own houses. They can go to the hotel to prevention of the families and take a look of all the material that they have in the platform related with the AIS COVID. And that's, many people explain to me, and now I say that is tremendous, because we have a lot of information from many places in the world. We have the information from China. Immediately we have the information from Italy. Immediately we have, unfortunately, Spain was the third one, and now immediately when another European countries, and unfortunately again, the experience of the United States, then probably you started a little bit, with some weeks later, but probably the experience of China, of Italy, Spain, Europe, and now United States could be very useful, in the majority of countries. Some countries probably they decided to do, different things, but I don't know.
One of the things you've described is an evolution. So you began by showing procedural videos, then interactive congresses where people can type online questions by chat that are answered, and congresses where there's a moderator speaking and asking questions of presenters and having the presenters answer. But the next stage in evolution might be the ability for even more interactivity, where the participants are showing something for assessment. In other words, skills assessment. So as we move to less travel, as we move to more private setting for doing things, even the examination by the American Board of Surgery has recently been given in a virtual platform as a pilot. Do you envision a way in the near future that video will be able to use to assess people's skills?
Yeah, that's very important. I wanted to, to start saying at the beginning, when you major in, some interference with congresses, could be, the societies, surgical societies, could be, say, those guys, what they're doing, because we are offer, all the information without registration, etc. Fortunately, thanks to, let me say, thanks people like you are very important for us, because you convince, to the people we are not enemies. We are, we are trying to compare with the soccer players, with the soccer matches in Barcelona. You have pay-per-view in TV around the world to see the Barca team, in a soccer match. At the same time, the number of people who wanted to go to the football stadium, increase. That is the reason, because, we can help to the society, and at the same time, the societies, of course, help us. But talking about the future, we created, a vertical dedicated to innovation. And innovation, remember, the most important mission of the AIS is education. And if you go to this innovation, now we are working with, of course, AI, we have, for example, in the last meetings, I don't know if you realize of this, augmented decisions. That means if some Congress, you don't have a good question because people is shy or I don't know exactly what, now the platform sent 3, 4 questions we call key questions, to motivate, to stimulate to the people. And that is absolutely performed by the platform. At the same time, we have all the analysis of the data, and now we are working very close with the simulators. With one good example in COVID-19 is now we're working with a Canadian simulator company, and we created a respirator, and it's crazy because you see the respirator in 3D, or you can make a curse. You just put the brand, and is coming from X industry, and immediately change, and you can have this. That is another important thing. We created, as you know, the telesurgeon. The telesurgeon is, for example, if I do one surgery and you can mentor the surgery, you can say, no, I think my recommendation is cut here, go to the inferior mesenteric artery, go to take down the splenic flexor. But at the same time, we created the revestration. The revestration means, experts is operating and explain everything without any possible, you can send to the 30,000 surgeons at the same time. We call the ubiquity. And finally, we have more on this, but finally, we are now working very hard with the robotic systems, and the robotic systems with AI. And let me introduce the concept of instead of 5G, introducing the concept of 6G. Now we are going to the 6G. 6G is 5G plus artificial intelligence. I think it's just a summary. We have many projects, as you know.
I thank you very much for your time, your insights, your expertise. Of course, obviously, for your friendship, but very importantly, what you've done to advance pre-surgical education. You've equalized it, you've made it just as accessible for a surgeon in a remote area of the world as it is for somebody living in a major urban center. You've made it just as accessible for a junior surgeon as a senior surgeon, and you've allowed us to learn from each other's disciplines. So thank you for your tremendous contributions, which in part is why you quite rightly and justifiably earned your honorary fellowship in the American College of Surgeons for this service to the global community of surgery and therefore of our patients. So thanks again for all you do, and thanks for your time today.
Thank you very much, Steve. But let me just a few words saying, okay, we are making something I think is good. Now we are, improving our, our importance probably in the surgery, but it's thanks to people like you, because particularly you collaborate, create, inspirate, create many of all the contents that we have the platform. And remember, you open me, a simple Mallorquin from Mallorca guy, just a simple surgeon who speaks terrible English, you open many doors. And I never forget this. And thank you very much. And I'm very, very happy to consider you like a brother. Thank you very much.